This week on the BackTable podcast.
Some of the common reductions in pain for the randomized controlled trials are far less in the real-world data. And this is the value of the real-world data. It's not, a specific patient treated a specific way by a specific group or person done with specific parameters to measure the outcome and compare it to another group. This is like anybody that has one condition treated by a number of different people all around the country that with essentially no inclusion and exclusion criteria other than the typical ones that are used in the region, and just kind of seeing what transpires, seeing how the person does. This data, this paper, this emphasizes that real-world data. If we do something radical, like actually collect our data and look at it, we seem to be doing a lot better than what's published commonly in some of the randomized control trials.
Hello, everyone, and welcome to the BackTable MSK podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on BackTable.com. First, a brief message from our sponsor. Stryker's interventional spine business offers the control you need, the flexibility you want, and the quality your patients deserve. Stryker is your partner in making healthcare better. From technology to training, from reimbursement tools to patient education, Stryker is there to support you every step of the way. Innovation is the driving force at Stryker. Their extensive product portfolio for vertebral augmentation and radiofrequency ablation procedures ensures that you have the tools needed to provide top-notch care. But their commitment to advancement doesn't stop there. With recent additions like the OptiBlate bone tumor ablation system and FDA 510(k) clearance for the SpineJack system for compression fractures that result from malignant lesions, myeloma, or osteolytic metastasis, you'll be eager to explore all the solutions Stryker has to offer. Learn more at www.strykerivs.com. Now, back to the show.
Hello, everyone. This is your host, Jacob Fleming, reporting from a beautiful day in Oklahoma City, and I'm here with the man himself, my soon-to-be former boss, Dr. Beall. How are you today?
Well, good afternoon, Dr. Fleming. It is a really nice day here, too nice to be inside, but this is an important topic, so I figured we'd take a few minutes to discuss. And soon-to-be former, meaning in about a month you'll be off and on your own, and it'll be an exciting time in your practice. I still remember my time on my own, and it was absolutely one of the best times that you'll have. And here's a little secret. All the times following will continue to be the best times that you will have if you do whatever it takes to make that career your own.
Well, thank you so much for that advice, and I absolutely agree with that. And for me, I'm interested in doing new things, trying new techniques that are better for patient care. But one of the other things I'm very passionate about, having trained with you, is finding those sort of orphaned conditions where patients are often left without treatment, and hence the topic of our discussion today, which is sacral fractures and particularly sacroplasty. So we'll just jump right in with the haymaker. Where are we with treatment of sacral fractures? We, as in the larger medical, how are we doing taking care of these patients?
I would say we're nowhere close to where we need to be, not even close. So let's compare the experience we have now and your status in life in terms of where you are versus when it was when I came out. So shortly after the earth cooled, I finished my residency, and that was in the late 90s. And I'm going to talk a little bit about some of the history of sacral insufficiency fractures, or SIFs, and a little bit about sacroplasty. So when I came out, it was in 1988, it's when I got out of residency. So sacral insufficiency fractures were described when I was in college. And it seems hard to believe, but Lori did the first description of sacral insufficiency fractures in 1982. So this was something that was just completely not recognized at all. And we know that the CT scanner came out in the 70s, and in the 80s we had MRI, but people weren't experienced enough or hadn't had enough exposure to some of these fractures that are difficult to see to even describe them. So it seems I can't quite fathom the fact that it was so late in terms of the ability to diagnose sacral insufficiency fractures. And if you understand why, you look at sagittal views, and people really focus on sagittal views of the MRI of the lumbar spine, and you got to watch the corners, because down at the bottom, anytime you have disruption, increased signal in STIR, decreased signal in T1 to the bottom of the corners, that is not normal. And it's difficult to see, primarily because a lot of times the axial scans don't go far enough south or inferior, and the SI joint has an increased signal. It can have fluid in it. It can have cartilage, or the articular hyaline cartilage in there, and it can have signal heterogeneity, and you just gloss over the fact that the sacral insufficiency fractures, which may be subtle in terms of their signal, you can gloss over that. Oh, that's the SI joint. My mind doesn't recognize it, so my eyes don't see it, and you miss these things fast and slow. The incidence of these fractures, the best data I could get for incidence of fractures, having just finished a teaching curriculum for the Stryker course on how to do this, was between about 4.4 and 12.4%. And that's quite a bit, and it's a fairly common fracture in people that are 75 years old or older. And so, as much as we think we're really good at recognizing these fractures, I can tell you that we still aren't great at recognizing these fractures. Okay, so what happens after you do recognize the fractures? Well, the first sacroplasty description was made in 2000, and that was done by a guy named Marcy. And this was done with sacral mets, metastatic disease to the sacrum. 2000, I mean, it seems just unfathomable, but it really was true, because I wasn't doing a lot of sacroplasty. I had done sacroplasty before the year 2000, but not a lot. And as soon as we started seeing more and more of these, I started doing more and more of these, and it was still kind of uncharted territory. And this was something that I started doing, just like 95% of the things that I do today, I never was taught to do in residency or fellowship. And that's not abnormal. That's kind of the normal course of things, and you have to keep on learning. The best thing that you can do is to teach somebody how to learn new things, and you could adapt your visual spatial skills and perfect those, and really understand the anatomy and the do's and don'ts and the general rules. You can quickly and effectively learn new techniques. But these new techniques have really been acquired in the last 24 years since that original description. And these are things treating sacral fractures. As much as we've improved, and we have improved treating sacral fractures, but still, if you look at the number of times these things are missed, statistically, it's going to be about 25% of radiologists. The real number is 23.5%. And 76% of other physicians, non-diagnostic related physicians, will miss these things. So we're still missing fast and slow. And if this isn't a compelling enough story, compelling enough case that we need to do better, how many people are treating underlying osteoporosis after fixing vertebral compression fractures? How many times have we seen this? So you've been with me for a year. I'd be interested in we've seen hundreds of fractures vertebral, and we've seen, probably 40 sacral fractures or something like this. How many times were these people already being treated for their underlying osteoporosis by someone else by the time they came to us? What do you think? What is a good guess number? I know we don't keep track of that. So what's somewhere in the range of 0 and -5%. Yeah. It sure seems like that. The demoralizing component puts it into the negative, I think, is it sure seems like that. There's hardly anybody being treated for it. And so we've got a long way to go. And this is one of these things that I can't really fathom how long we have to go. So, we have, hip fractures in the early 2000s, only about 22% of the patients were treated for that. It went down to 11% by the year 2011. And this was after an anabolic bone agent, teriparatide, called Porteo, made by Lilly, was introduced in November 2001 is when it was approved. And then we had April 2017, we had another anabolic bone agent, Temlos, abaloparatide. And then April 2019, we had romosozumab Evenity. So we now have 3 anabolic bone agents. And these people that get sacral fractures, that we had somebody in here that we thought had SI pain just this last week or the week before, somewhere in that range. And she couldn't get out of a chair. And that doesn't really worry me very much, but she's really tender. And her pain didn't seem to be with sitting. It seemed to be with movement and transition. And so, didn't really see anything that had to do with sacral fractures, but the transitional pain, standing to sitting to lying, getting up and moving around, comfortable as long as she wasn't moving. And sure enough, we sent her for a CT scan, and she had subtle but present and accounted for sacral insufficiency fractures that had been missed over the course of time. So I think this is a combination of vigilance, knowing that they're there, especially after pelvic radiation. People after pelvic radiation, high rate of fractures, and 80% of those fractures in the pelvis will occur in the sacrum. And this is something that should occur at the elderly patient. And I bring that original patient up because she was somewhere in the range of 65, 66, maybe even a year older than that. She wasn't 85, and I told her that, this is something we typically see in 80, 85-year-old thin Caucasian females in Northern European descent, are people that otherwise have a biogenetic predisposition for sacral fractures, and, it's not abnormal, whatever the reason. She had multiple factors, which are beyond the scope, but nevertheless, it's something that raises the level of importance for treatment, raises the level of importance for vigilance, and just that little clinical scenario is something that really, hopefully, will stick with us both to know the difference between SI pain and sacral insufficiency fracture pain, even though they're about, a few millimeters to a centimeter distance from one another.
Yeah, it's very difficult, I think, clinical diagnosis when it's not on your plate what you're thinking about. And for some reason, it's just commonly not. Even for us, it's not kind of the first place where we go with the diagnostic criteria that we're thinking of. And we actually put that patient on the table, on our fluoro table, and had a look just because the suspicion was so high. And as we know, most sacral fractures are not readily apparent on radiographs, but it demonstrated the difference between reading a study blind and looking at your own patient who what you're looking for. And we did see some subtle kind of cortical disruption, and that kind of sealed our suspicion. We sent the patient for CT. And I think that commonly this is just not thought of by kind of the first line diagnostic physicians who are involved in this. If a lot of these patients have at least gone to the ER once, if not more, and these can often get glossed over. As you said, a lot of times it's very subtle. And a lot of times I feel that we just see kind of a trabecular disruption on the CT. And MR, of course, you may see increased stir signal. That's the thing we look for, but you can have fractures without much stir signal as well. Is that right?
These fractures are notoriously difficult. There's no way that we would have seen them had we had a high level of suspicious to see them. Looking at that and finding the little cortical disruption, that it's one of those things very hard to see, but once you see it, you can't unsee it. And it's there. And sure enough, it was there on CT scan. You see what you look for what you know, and that saying is based on Nobel Prize winning data from Hugo and Weasel in the 70s. But that really is, the visual cortex and the neocortex are related, and once you know it, once you see it, you have to be able to recognize and know what you're looking for to be actually be able to see it literally. You have to be able to see it figuratively as well. So these are things, and patients like this will commonly get missed in physical examination tests for this. Physical examination tests for SI pain, the sacral thrust, sacral compression, Gainsland's, Patrick Faubert's test, and the distraction test. These are in addition to things like Fortin's finger test. These things are this positive in patients with sacral fractures because the lines of force go vertically up and down through the sacral ala. They typically affect S1 and S2 predominantly, a little bit of S3 commonly. And then the force across the body of S2 is the side-to-side force. And these things will transmit down, as you know, based on the Lindstrom data, biomechanical data, down through the superior and inferior pubic ramus. And that's why you have sacral fractures associated with pubic rami fractures. And the first thing we have to do is look at pubic rami and scour the rami to make sure they're not fractured as well, because that provides additional instability to the pelvis. And just cementation may not be enough. I mean, the trauma literature says that any gap in a sacral fracture of about 10 millimeters, 1 centimeter or more, and you really probably should be using hardware as well. In my experience, these are not the same. You can't apply trauma rules and requirements to osteoporotic fractures. We try to, because we don't really have enough data there for sacral insufficiency fractures. But so we do apply that now. Anything more than about a centimeter or more in terms of a hypotrophic or ligotrophic non-union, a gap after a sacral fracture, we will go ahead and add screws, as you know, as you have done. And we've seen a good amount of success to this. And we kind of a low threshold to adding screws anyway, because that's what we do for other sacral pelvic pain scenarios, such as SI joint dysfunction, and it's fairly easy to do. So we have a low threshold to do that. Do we do it too much? I hope not. And I surely don't think we do. But that's, applying, an L1 burst. If grandma falls down from a standing height, she has a fracture medial-laterally and anterior-posteriorly bigger than the level above, level below. What is it? It's a burst. But we don't hesitate at all to treat it with standalone cement, just vertebroplasty, kyphoplasty, and now spine jack, of course. But, we treated this for years. It's very different from a high-velocity injury where, you drive your car into an embankment on I-35 and disrupt your PLL and, have a traumatic burst. These are very different things. And I think the same thing applies to the sacrum. It's very different than a motorcycle injury with a shear force, using the Burgess scale to figure out exactly the mechanism. These are different issues. These are more traumatic issue. But I think we have a long way to go. I think we really need to have the ability to do sacroplasty. And one of the things I see commonly in our registry and enrolling people for sacral fracture fixation is there's not very many people doing this. So in our state, I think there's 2 people doing sacroplasty. I think my former fellow and us. So 3 altogether, soon to be 2. But it's just not the number of people that do this. There are not nearly as many people that do sacroplasty as that do vertebral augmentation, and that's kind of a real travesty. One of the things that we have seen is that this is one of the best things that not only the people can do, but that is done. The mortality rate from sacral insufficiency fractures and the common things that we use in terms of pain and debilitation. So I'm going to go back a half step, and here's what happens when we don't recognize them and treat them. The 1, 3, and 5-year mortality rates for sacral insufficiency fractures, and I'm going to quote some data. This is from Chandra, who did the best systematic review and meta-analysis on sacral insufficiency fractures, and the classic paper from Babiev that here's what happens if you don't treat these people that have sacral fractures. The 1, 3, and 5-year mortality rate ranges from about 11.5 to 23.5 to 20. Almost 27% in 1 year, 3 years, and 5 years. If you don't treat somebody with a fracture, by the time you hit a week, the bone loss goes up to 50 times normal bone loss that's age-related, 50 times, which is crazy. At about the 2-week time point, you're cracking along at about, you lose 10 to 15 percent of strength every week that you're down, and by the time you hit 2 weeks, about 10 days to 2 weeks, you're at about equivalent to a 10-year loss, age-related loss in conditioning, bone and muscle. And by the time that you're 5 to 6 weeks out, you're half as strong as you once were. That's just incredible to me. And you put a young guy down, 20-year-old male, and the bone loss is very swift too. If you measure the calcium goes up, bone loss goes up. And this is something that happens in younger patients too. It's just more debilitating in older patients because there's no reserve there. I mean, you get the idea that if you thump them too hard, they lose their grip on the edge of the sink and go down. And this is not something they can or should or have to withstand. And by the time these people are discharged, the Babiev data is, half of them can't be discharged at the level they once were when they came in. And 40% of them will have chronic pain. 40% will have chronic pain. Just can't imagine that. And there are people that would advocate for non-treatment because it's too risky to do treatment. Too risky.
Yeah.
Too risky. What about
is the lack of treatment?
What about we compare the treatment versus the non-treatment? In the U.S. Registry, there was one case of extravasation with neural injury. One. There's one case. If you combine the vertebral augmentation and the sacroplasty registry, there's one patient total out of 732 patients in the vertebral augmentation, 102 in the sacral augmentation error analysis. One. The mortality rate at 5 years, 27%, 26.9%. Mortality, people that are dead. And we conducted a long-term follow-up. Mike Fry did the original paper. It was 52 patients and said that, the pain goes, from an 8.1 to 3.6, like immediately after the fracture repair and down to a 0.9 a year out. And we got the idea a few years back to, I wonder what happens to this long-term cohort. And that was post-2007. And so we did it. This was right around 2018. We wanted to publish a 10-year follow-up. And so we look back 10 years, late 2017, we look back, and the pain score went from an 8.1 to 0.9, as I mentioned. And 10 years out, the same cohort had a 0.5 pain score. It was maintained out through 10 years. And the cohort that did not receive treatment, we put in the paper that these patients weren't contacted, is the way that we put that in. And we debated on what to say about this. The reason they weren't contacted is because they weren't living. There was nobody still alive at 10 years after their sacral insufficiency fracture. And, we kind of elected, I thought that was a little bit too powerful of a statement that would take away from the main message that sacroplasty works and is durable. I didn't really want to put surrogate mortality data in there because it's not a mortality. It's not a mortality article. It's not a claims-based mortality article that we've seen with Abed and his two papers, Chen, Kevin Ong, Josh Hirsch, and our group publishing this with the entire Medicare claims database. And that's the way to do it, propensity score matching the mortality data, being really sure how much good we're doing for people. So we elected not to mention that, but it's due to a combination, not only the fact that sacroplasty, sacral insufficiency fracture is associated with a really high rate of mortality relative to other conditions, but people are old. How many, the average patient, when you say, I have a patient that needs a sacroplasty, in my mind's eye, I see an 85-year-old Caucasian female. And that's who I see, because that's who typically gets sacral insufficiency fractures. They're about 10 years older than the people that typically will get a vertebral compression fracture. And how many people that are that range will be alive in 10 years? So, of course, there's natural causes. People die of deconditioning. They die of pneumonia, by and large. And then one of the other things is pulmonary emboli from DVTs, from laying around in bed. And one of these other interesting things that I did, that I learned putting out the sacroplasty curriculum, the how-to, and we did this how to do a sacroplasty because there's nothing out there. And that's probably one of the questions I get asked the most. Hey, I want to do this sacroplasty. I know it's beneficial. I want to start this up. How do I do it? And I sent him a book chapter, the book chapter I did with Michael LaPalma a long time ago. And I sent him a talk on sacroplasty. I sent him some examples, and I've done some work setting up how-tos in kind of a vestigial form, not really something that was extensive. But I thought that was really important. And one of the things that I've learned in the Babiev paper, people said they had included bed sores. And I thought, wonder why I include a bed sore in there. I mean, things like coronary dysfunction, heart dysfunction, it doesn't, the ejection fraction goes down. The pulmonary efficiency goes way down. forced vital capacity goes way down. You get pneumonia, you get DVTs and Ps, and then, urinary tract infections, and then pressure sores. But I looked this up, and pressure sore has good Medicare data. I was surprised about that. But if you develop pressure sore, it's defined, and the cost that it takes to treat that pressure sore ranges at the low end $20,000, and on the upper end $150,000. It's really a little bit over both of those values, but that's the approximate value. 20 to 150,000. There's good Medicare data on this. So it turns out, granddad lays in the bed and gets a fracture, especially, sacral decubitus fracture over his fractured sacrum. That's going to impede our ability to treat, because one of the only absolute contraindications is an active infection in the region of the treatment site. And that's a tough one. You'd have to do an MRI to make sure he doesn't have osteomyelitis. And if it's just a superficial fracture involving the skin and the underlying soft tissue, then you go lateral. You probably do the lateral-based trans-ilium approach to the sacrum and go across S1 and then across S2, or do both of those if needed. But that's, these are things that provide a tremendous amount of debilitation. And not to mention the fact that what I said previously, that 40% of these have chronic pain. I don't think I've seen a case of sacral insufficiency fractures with chronic pain in 10 years. I don't recall a single one of these. We typically fix them. They get better. They stay better because we use anabolic bone agents to bring the bone density back up. And maybe they're out there, but they're there without my knowledge.
Absolutely. And you gave us a whirlwind tour of the current data, and do have to give a shout out to the most recent article in JVIR, which of course you're head author on, the Sacroplasty Registry interim analysis of 102 patients. And this was one of the winners of one of the best papers of the year at SIR.
Yeah. How about that?
How about that from, just a really excellent and overwhelmingly humble group of researchers. But we will, of course, link to that as well as the other literature that you mentioned. And I'm really glad to focus on that, because this is something that, even as a resident a few years ago, there seemed to be kind of a dearth of good literature out there. Of course, the Fry study, as you mentioned. And now with the interim analysis, I think we're really starting to show the power of this technique to keep away from what you describe this downward spiral that happens in these deconditioned patients. And of course, that's predominantly the patients that we see it in. But as you mentioned, pelvic radiation, sometimes we're seeing even young patients, in their 40s, even men who've undergone pelvic radiation, and they are more prone to do this. And so it's something we have to keep in our differential diagnosis because it can pop up if we're not expecting it. So you talked a little bit about the technique, and I definitely want to get to that. And one of the things I wanted to mention first is that I think every time this gets brought up at a meeting, inevitably there will be a question of is CT or fluoro better?
Sure.
And I think that's a really interesting question, because a lot of our colleagues have easy access to CT. Paradoxically, easier than the more primitive CR, which is really all you need. And could you just say a little bit about your thoughts to people who are looking to add this on to their practice? How would your...
Sure. I'm going to tie that to the registry data and then really go back. And there's a couple more things I want to put together in terms of, I want to put the fit and polish on the literature data. But the registry in general, I just want to have a comment about this, and I'll get to the CT guided versus fluoro guided and what's better. The secret is coming. It's coming here in a few moments. What's better? For those of you guys out there listening to the BackTable, I want to tell you that yes, it is an award-winning paper. Yes, it was published by JVIR, and yes, this has been recognized by a number of different outlets. It's been popularized. It's been put out on press releases, and it is one of the most salient pieces of literature that has gotten rejected 3 times before it was accepted. And finally, the revision was accepted to JBIR and not out to Daniel Zay. He recognized, I think, that this had incredible value, but the point is don't lose focus. Don't assume that your paper is bad when it's not. Some of the best things I've ever written have gotten rejected the most times, and vice versa. And I've gotten comments back from the registry that they criticize the fact that we didn't have a control arm. And I'm like, this is a registry, right? It doesn't have a control arm. This is a prospective, multi-site collection of data, similar to a post-market FDA phase 4. This is as treated on-label type, collect the data in the real world and see how people do. And I've had comments that are that vacant by what should be expert reviewers that are not expert. Otherwise, I even put the word registry in the title of the paper to specify what this was, just so people wouldn't make a mistake. And there was comments for their reviews, of course, that were excellent and very accurate. There were also reviews for the papers, the times that we submitted to a couple of the other journals that were not excellent, that were pedestrian, that were simplistic, that really, you get the idea of reading the reviewers' comments. They didn't even know what they were reading, didn't have enough expertise to be really judging this in a critical way. Having said that, we were finally glad that this found a home in JBIR, and I think it's one of the most salient pieces of literature. And I'm going to make just a quick comment about the literature. The problem is with sacroplasty is this doesn't have industry sponsorship. And you take industry away from the sponsorship for the research data, you have, of course, no research data. And who's going to pay for this? The academic centers? Well, okay. Where's the research? I mentioned the original paper done by Mike Fry, pain score 8.1 down to 0.9 of the year. Keith Cortman, he had 200 plus patients, and the average pain score 9.2 to 1.9 at a year. I mentioned Chandra's meta-analysis and then our registry data, and all these are very similar. So our pain pre and post, pre 7.8, after 6 months 0.9. And the reason why this real-world data is important is because this amount of pain reduction. So in the Evolve trial, the largest as treated on-label kyphoplasty trial, the amount of pain reduction was 6.3. The average amount of pain reduction in the U.S. registry out of 1,000 plus people enrolled with full data sets collected on 732 is 6.7. And the average, if you've been keeping track, mentally, the average pain reduction for 102 patients on interim analysis of sacroplasty was 6.9. So explain this to me. So if you have a bunch of trick people out there just kind of treating fractures, and I don't really screen the number of sites that we enroll. I kind of have an idea about who's doing what, and I wanted to get these sites distributed all throughout the United States. So we'll take people from West Coast, East Coast, North, South, Middle, and I kind of want to distribute this around. And it's a little bit of a crapshoot. So you roll the dice on this thing, and you're getting a 6.3 to 6.9 point reduction in pain. What about the free trial, the seminal trial comparing kyphoplasty versus 3.5 point reduction? Half, basically. And, the Pompidou-Sassio meta-analysis with 50, it came down to be 27 level 1 and level 2 articles out of, over 1,000 papers examined, 4.55 reduction in pain. Well, if you turned out and some of the common reductions in pain for the randomized controlled trials are far less in the real-world data. And this is the value of the real-world data. It's not, a specific patient treated a specific way by a specific group or person done with specific parameters to measure the outcome and compare it to another group. This is like anybody that has one condition treated by a number of different people all around the country that with essentially no inclusion and exclusion criteria other than the typical ones that are used in the region, and just kind of seeing what transpires, seeing how the person does. And so this data, this paper, this emphasizes that real-world data, if we do something radical, like actually collect our data and look at it, we seem to be doing a lot better than what's published commonly in some of the randomized control trials. So, and this, some of the registry data that we published and to mention the parenthetic comment on this is ongoing. I want to run this out to 250 patients, and big nod to the SIR Foundation that sponsors this, sponsored by the SIR, the Society Foundation. And we were so successful in the vertebral augmentation registry at enrolling patients quickly and cheaply that we had room to do some other patients. And so we did a sacroplasty registry, and hopefully by the time this is all done, we will have 250 patients. And this is important because, as you know, Medicare and some of the other payers are kind of consistently mining the procedures that are done and often draw things into question. And in a lot of Medicare regions, the sacral kyphoplasty has a T code. It's really lumbosacral vertebroplasty. It's what's coded. And this is done a little bit to protect the reimbursement. And by protecting the reimbursement, what I mean by that is protect the patients against the increased rate of mortality, dramatic increased rate of mortality, chronic pain, dysfunction, UTIs, pressure sores, and everything else that come along with untreated sacroplasty. Because if you don't reimburse for it, nobody pays for it, very few people get treated, and you're relying on things like cash pay, which is, I think, totally unacceptable. So a lot of this is done just to see how we do, and we know how we do. We do pretty darn well, and now at least the interim analysis has put that in terms of data, real-world outcomes. It has put that in print. And if you look at the data of the sacroplasty, I mentioned that it wasn't no industry sponsorship. And the article that we published in the 10-year follow-up in the original paper, this was level 3 evidence. There's no level 1 evidence, none. And we have to have something like real-world outcomes, patient-reported real-world outcomes, to be able to put, firm flag, plant that flag. Here's how we do. Here's what's done. And then, one of the few papers done recently by Liu et al., 2019 paper, I love this paper because most people say you do vertebral augmentation or you do non-surgical management. And then if you do non-surgical management, suddenly, poof, the people do what they do, and you record them. You don't really record fastidiously all the AEs and SAEs. I think they just go into the pool. It's non-surgical management, conservative. Well, then you record all the AEs and SAEs in the vertebral augmentation. What Lou did is he recorded both augmentation and non-surgical management and found AEs and SAEs 9 times more commonly in the patients treated with non-surgical management than the ones that were treated with vertebral augmentation. And this was a kyphoplasty trial, but it certainly does have some overlap in this. And I want to try to preserve this for the people who need it. As my mother is, of no surprise, is a thin Caucasian female, Northern European descent at the age of 80. And, if she fell down and had a sacral fracture or vertebral fracture or developed sacral insufficiency fractures, for God's sake, I'd want somebody to be able to fix her if she wasn't in my area and wasn't able to get back, and do so without any blockade or any type of hurdle. So rolling back to CT versus fluoro. So here's how it broke down in the sacroplasty registry. It was interesting. So 7% of the time, balloons were used as compared with, most vast majority in the vertebral augmentation registry. We had 35% of patients used CT versus about 3% in vertebral augmentation registry. 35%, and then there was about 7% that used a combination of cone beam, CT, plus fluoro. I was surprised that wasn't a little higher. And then the rest of it was done under fluoroscopy. And so the advantages, of course, under fluoroscopy is it's quicker, it's pretty easy, it's very prevalent. I mean, we do our cases with a marginally competent C-arm held together by tape. And then you have the other option of, but it requires more expertise, more experience. You have to understand sacropelvic anatomy, and it's been my experience that this anatomy is probably not understood as well as it should be across the board. And then with CT, you get a better view of where it goes. You get a better view of extravasation patterns into the sacral foramina, close to the lumbosacral trunk, then the lumbosacral plexus, into the spinal canal, if that is applicable. But it's slower. and it's more expensive, and it's more cumbersome. And some of the original sacroplasty approaches that we do now, we developed under CT, and then did it worked backwards. I call that working backwards, developing under cross section, figuring out what's a safe approach based on anatomy, figuring out what to look for in terms of extravasation patterns, and then taking that, extrapolating that back into what I perceive as quicker and easier. And as long as you have enough expertise to watch for the extravasation patterns, you're okay. And the extravasation pattern that you have to watch out for is people think it's around the foramina. Nope, it's anterior around the lumbosacral trunk. So if you don't know what a pelvic inlet view is, please get on your computer and look up pelvic inlet view, because that is what shows you the pelvic brim anteriorly. And you want a sharp line, and you want to see absence of extravasation anteriorly, because the lumbosacral trunk and then that becomes the lumbosacral plexus goes along the anterior portion of the sacral alet. And if you extravasate around that lumbosacral trunk, both you and the patient will hurt greatly. So that's the only complication that we saw in the Sacroplasty Registry, was one of these extravasations. And when people present with SI pain and with sacral fracture pain, they'll commonly present with yes, pelvic girdle pain, yes, low back pain, yes, posterior hip pain. But it is really common to get an L5 radiculopathy, and variant of L5 radiculopathy means pain in the groin, and then pain that radiates down the outside of the thigh, over the top of the knee, front of the leg to the top and bottom of the foot. That is an L5 radiculopathy. And of course, you can add certain variations. I mean, it can affect the S1 or the L4, but mainly it's an L5. And this is a pseudo radiculopathy, pseudo sciatica, because it's just being irritated. And it's being irritated by that lumbosacral trunk. So that's one of the things. It was a stretch movement of the pelvis bony anatomy with irritation that either comes from sacral pelvic dysfunction, SI joint dysfunction, or a fracture of the sacral ala. You can have a pseudo radiculopathy. So I've heard people say, well, it can't be a sacral insufficiency fracture because a person has sciatica. Whoa, be careful, watch out for that, because that does not mean that. In fact, you hear some of our receptionists talking to the patient, and they'll ask if you have do you have that wraparound pain, and do you have that pain down your leg, and they don't know that you're not supposed to have sciatica or sacral fractures, but just talking to enough people with thoracic pain, thoracic radiculopathy around the ribs, sacral fractures, and sciatica down the legs, they've suddenly become expert in this, and that's what happens when you talk to a lot of people and get a lot of feedback on that. That really, it plays out well. And you understand, you get a good understanding of the pain patterns of presentation, and you're not, most importantly, you're not don't have a lot of influence by your colleagues telling you, oh, this can never happen, that can never happen. Stay away from this, stay away from that. Don't use this, don't use that. I mean, that's one of the worst things that can happen. And, I think for sacral insufficiency fractures, the best thing that could happen is a sacroplasty followed by treatment of the underlying disorder of osteoporosis.
Absolutely. And so we've seen with time that the people who have added this to their practice have unanimously said it's one of the best things they do. And you've outlined that with the data that's been rigorously collected to this point, and we do want to continue expanding the registry. But so this is something that I think it's a matter of a lack of awareness, and we've seen this with, I think, the majority of patients we've done a sacroplasty on this year. They were initially, if not persistently, told there was nothing to do for this fracture. Just let it heal. And that dichotomy of treatment versus non-treatment, and the treatment nihilism, as you refer to,
the Friedrich Nietzsche of treatment. The treatment, there are much of treatment nihilists.
This false dichotomy that it's, just let it heal. And we know that a lot of them will not heal, and versus more of a ortho trauma approach, as you spoke to earlier. And it brings up the adage, kind of an old AO adage, that metal does not hold bone, but bone holds metal. And so even when we're doing something like what I would refer to as an augmented sacroplasty, putting in hardware, we wouldn't think of not doing that without cement, because these patients are severely osteoporotic most of the time have, just butter.
And it's the corollary to that, AO, is if the bone doesn't heal, the hardware will fail. And that's a good cardinal rule. I mean, the bone quality is everything. Knowing how to help that bone heal is also everything. Yeah, some of the new 3D printed screws that we have, the ability to, that are, approximately 60% porous, very similar to cancellous bone, and that really have the diameter of the pores are similar to the diameter of cancellous bone, 200, 300 microns. I mean, they have what's called the wettability and excitability. These sound semi-obscene, but they're descriptions of titanium alloy screws, the ability to take and conduct things that are liquid, including blood, with all the factors and the growth factors in the blood, and the ability to exchange the 2+ cation versus in the calcium onto the screw. And these things are very effective in terms of providing good long-term relief. And the people that will say, "Oh, it'll heal," okay, yeah. I mean, I don't necessarily philosophically disagree with that, but if Plan A is rest analgesic bracing, Plan B cannot be rest analgesic bracing. And I would also call into question Plan A. Why would you use rest analgesic bracing when you know it's 9 times more risky? Why would you do that, knowing that if this guy gets a pressure sore, that's going to be worth $150,000? How many sacroplasties does it take to match that? Right? It's one of the cheapest things that we do. And how much when people get into, they have sacral fractures, the average amount of time that is unrecognized is 29 days. Unrecognized, average amount of time. So don't worry, it'll heal. Okay, what happens when it doesn't heal? Do all fractures heal? We see them every day. We will see them tomorrow. We will see them the next day and the next day for fractures that haven't healed. Fractures don't always heal. And if you have an oligotrophic or hypertrophic non-union in your femur, you know it because you can't freaking walk on it. But if you have one in the sacrum, it's hard to walk, but you can walk on it. And people will say, "Oh, don't worry about it. It'll heal." And that can't be both Plan A and it can't be both Plan B. And this is something that oligotrophic or hypertrophic non-unions leading to the so-called Kummel's disease. It doesn't really exist. I mean, it's really a hypertrophic non-union developing a cleft in the vertebrae. You can also have chronic clefts in the sacrum. We've seen lots of those. And these are things that require additional stability to heal. And 29 days on the average. And if for a patient that has a fracture, that is, I'm going to roll back to the vertebral fracture because the data's been collected with this. And if somebody goes in with an acute vertebral fracture, they're in the hospital on the average of 8 days. And, 8 days of opioid control and bracing, and typically on the average, a 75-year-old patient doesn't seem like a good idea. In fact, it's not. We've discussed what happens when you don't treat these people. And these people just don't do well. They don't come out of the hospital and they don't get back to it. The statistic on hip fractures is 50% of the women that get a hip fracture, even though it's treated, will not regain their previous level of function. 50. It's very similar to that in sacral insufficiency fractures, and 40% of those people have chronic pain. And so let's not let these people suffer because of shame and unrecognition, lack of recognition. I hear often that it's a failure of treatment, either medical or augmentation, and it's really not a failure of treatment. It's a failure of recognition, seeing it, and it's a failure of diagnosis, thinking about what this could be, and coming to formulate, again, thinking with a good treatment plan based on literature data, based on the things that we know for sure. And these are the things that hopefully we're going to start popularizing pretty soon with sacroplasty treatment courses. This, again, is one of I do commend my colleagues. This is one of the things that people are interested in the most, and the single thing that they probably want to add to their treatment armamentarium, at least among interventional radiologists and people that practice interventional pain. And this can be a very valuable thing that's added on, and it should be added on. This is undertreated in terms of the number of people that do vertebral augmentation versus the number of people that do sacroplasty. We need to really expand the number of people doing sacroplasty, and we'll see concerted effort to do that.
That concludes part 1 of our conversation on sacroplasty with Dr. Beall. Tune in tomorrow for a discussion on procedural technique, clinical pearls, and opportunities for training. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable MSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Junwoy Kennebrew.
Thanks again, and see you next time.